nursing session. Uh, Topic is nutritionally in critically ill patients. Our speaker is Dr. Sharmili Sinha, is the renowned intensivist in Bhubaneswar, in Apollo Hospital, Bhubaneswar. She is the executive committee members of National IACCM. She is the chairman of past chairmen of the Bhubaneswar branch IACCM. She has multiple publications, and she is also EDIC and DNB in critical care, and other highlight of around 85 guest lectures, and area of expertise in neurocritical care, polytrauma, sepsis, ventilators. So she's excellent speaker. So now mic to you, Dr. Sharmili.
Thank you very much, Dr. Tyagi, for your kind words of introduction, and to ICCM team and team by Indian College of Critical Care Medicine for this opportunity today. So my dear all friends and colleagues who are listening to me today, actually nutrition is one of my interest areas, and it's very, very important part and parcel in the management of ICU patients. So we'll see in the next 30 minutes, how do we go about nutrition in critically ill patients. So the learning objective of today's session will be to understand under these headings, like why important, how do we assess it, how to start, and what are the route preferences, and how much calorie and protein we give, complications, and what are the real-time or real-life challenges that we see in delivery of nutrition in ICU patients, because there has been so much discussion and emphasis in but why in ICU patients? We'll look at familiar with this mnemonic, gut or nutrition, and also glycemia. So this gut, it implicates the nutrition status, how the nutrition plan of a patient who is in ICU. So this is very much a part and parcel of critical care management of an ICU patient, and it is essential for all CHOS patients. So why it is important? Why are you concerned about it actually? Because if you see, the malnutrition and its associated consequences have a definite impact on the patient outcome. So what happens, how it causes this impact is that at cellular level, which is not seen, but it continues to affect the organ systems at physical level. Physical means when you go and see the patients by the bedside, you can see the impact of malnutrition in such patients. And also it affects the psychology. So at cellular level, actually it can cause, reduces the immunity and predisposes to infections. Stress ulcers can happen in the stomach. It is very known that it is associated with delayed wound healing in patients who have got surgeries done, or if they've got traumatic wound injuries. There is reduced nutrient absorptions like vitamins and essential minerals. There is altered thermoregulations, and these patients tend to become hypothermic or also develop hyperthermia, disproportionate hyperthermia if there is sepsis. And also functions. So how do we see it at the physical level? You see, if there is a nutrition is compromised, it affects that muscle strength, and as cellular level function also affects, because for patients who are on respiratory support like ventilator, either non-invasive ventilator or invasive ventilator, it interferes with the ventilator weaning, because if there is no muscle strength, the muscle is fatigued and or it is atrophied, then chest wall cannot expand or properly, and it will definitely impact the respiratory weaning from the ventilation. Also affects the cardiac function, because myocardium also has got muscle content. It leads to atrophy of the visceral organs. What are the visceral organs? It is liver, kidney, as we mentioned, that it can compromise the kidney functions, and also the gut and all other tissues which are not visible from outside also get atrophy. There is loss of body weight which is visible to the eyes, and many times patient attendants, when they come to visit the patients in ICU, they also complain at these things, because there'll be visible, checks will be shrunken, there'll be muscle mass will be shrunken, and patient will look weak. That is got a lot of impact on the patient psychology also. So overall, it increases the length of hospital stay, increased rate of all the complications you name in ICU, they are directly or indirectly related to nutrition status. And overall, this leads to increased mortality rates in ICU. And of course, the longer the stay in the ICU, the healthcare cost is increased. So it can have dire consequences if you are not able to achieve the nutrition goal among high-risk patients in ICU. Because these are three important phenomena, like for patients in the ICU setting, they receive only 50% of target calories from one day to the next. Because there is a lack in planning or, and or lack in execution if in the nutrition plan. If you're deciding certain amount of calories, patient might have actually received only 50% of the target calories. So if there is accumulation of this calorie deficits per day, you just imagine at the end of 7 days or a week, there'll be huge calorie deficit, which will definitely have an impact on the patient's nutrition status, immunity, and overall all other organ outcomes. And 74% of patients who are on mechanical ventilation fail to attain even 80% of their energy targets. So it is, as I said, it has a direct correlation with the winning from mechanical ventilation, because respiratory muscle strength is definitely required when the patient is improving from the lung injury, either from the infection or the ARDS that we talk about. And when it is associated with the failure to attain the nutrition goals, there is increase in the ventilator days, as a result, increase in complications and hospital stay. So malnourishment, in summarizing, can increase morbidity, mortality, length of stay, and cost of hospital care. Everything goes up. So let's have a quick look at this pathophysiology of malnutrition in critically ill patients. This is a beautiful table derived from our authors of Indian Journal of Critical Care Medicine, published in 2020. You see, when there is critical illness, there is release of lot of inflammatory mediators. I think most of us know about these inflammatory markers or mediators, especially that we have spent time through the COVID pandemic now. We talk about inflammatory markers all the time, like IL-6 or on CRP or procalcitonin. So there is a lot of release of this inflammatory mediators. And also there is pro-inflammatory mediators, which include mostly the interleukin-1 or interleukin-6 or TNF-alpha. And there is also release of this catabolic hormones, which increases generation of the endogenous energy substrates for the vital support of the vital organs. And at the same time, there are anti-inflammatory mediators also. So all this, actually, there is a complex interplay of all these inflammatory markers, which need to loss of lean body mass. And if it is not supported by adequate nutrition therapy, it can lead to malnutrition. Hence, nutrition therapy is of utmost importance. Let's look at the prevalence of malnutrition in the world and in Indian scenarios. I would say mostly the Indian and the global scenarios are almost the same. Global, it varies from 20 to 50%. And in India, we stand at around 40%. I would say if you're taking a very close or detailed look at malnutrition, nutrition assessment in ICU patients, it would be slightly more. And if you're dividing this malnutrition into mild, moderate, or severe category, most of these patients actually come into the moderate to mild categories. So actually, it is not too bad, but still we have, deficiencies that we need to address. So who are the patients who are at the risk of malnutrition in ICU? Obviously, these are the patients who are already compromised before they present to ICU. Somebody who is grossly underweight or somebody who is grossly overweight also. So just remember that, if the body weight is high, that does not necessarily mean the patient is healthy. Somebody who is overweight or obese is also actually a kind of malnourished. And patient who have got a history of recent weight loss, more than say 10% over last 3 to 6 months, they are usually having some significant underlying pathology, which has actually brought them to ICU. Mostly these patients we see, they are either the patients who have gastric problems or intestine problems or occurred cancers or tuberculosis. Also patients who are alcoholic also or in drug abuse, they also are usually malnourished because they don't eat their food well. Somebody who has been nil by mouth for more than 5 days, they start actually getting into the phase of catabolism. If they have diarrheas, malabsorption syndromes, burns, trauma, and overall sepsis patients, they all suffer from high degree of catabolic state. Hence, after a period of say 2 to 3 days, if you are not starting supplementing their nutrition adequately, they go into a state of catabolism, as we saw in the previous flow chart. And there is a lot of wasting you see when the patient starts recovering. And at that point, when actually the primary sepsis would have resolved, and if the nutrition has not been taken care of, they tend to develop more of this nosocomial or hospital-acquired infections. There is difficulty in weaning from ventilation, and there is also more instances of bed sore in these patients. So how do we assess nutrition in ICU? It's very, very difficult, and I think it is one of the areas which is seriously lacking still in intensive care units. But summarizing, there are two main scores which have been devised to assess Nutric scores in ICU patients. Many of the nursing charts actually having these scores in place. In Apollo Bhubaneswar, in the nursing chart, I could not get a photo of that actually, but in our ICU chart, this Nutric score is already printed. So what the nurses have to do is they have to see these parameters like age, Apache score, SOFA score, or the number of comorbidities. Comorbidities means like hypertension, diabetes, asthma, COPD, or they have chronic kidney disease. All these things they have to find out from the history and give a score. And also from days from hospital to ICU admissions. And if the patient has got a report of interleukin 6, that is also added. So higher the score, the worse is the nutrition status. And for the SOFA score or the Apache score, you can take help of the doctors. So these are numerous scores have been devised actually in the last 30-40 years. But I would say in only these two tests, as I said, mentioned about this Nutric score and this nutritional risk screening 2002. These are the two scores. These are varyingly followed in different hospitals. In our place, we follow this Nutric score. All other nutrition assessment scores are a bit complicated, hence not generally practiced in ICUs. And this is the nutrition assessment 2002 score. This is a bit lengthy, but nevertheless, it is usually printed in the nursing chart, whereby the nurse, only attending nurse or the dietitian, can just check for these parameters and give assign a score, and you can judge what is the mild, moderate, or severe risk of malnutrition for this patient. And accordingly, this patient require frequent re-evaluation. Because suppose you have seen the patient on day 1 and day 2, you have devised a nutrition plan. These patients, those who are at moderate or higher risk, they need to be reevaluated a bit more frequently. In our ICUs, every day a dietitian visits, but in setups where it is not possible to have daily dietitian visit, at least every alternate day or third day, a nutrition dietitian can come and engage in discussion with the bedside nurse or doctor to optimize the nutrition. So when to start nutrition? It is as early as possible. As we talk about antibiotics in sepsis, hit hard and hit early. Like that, for nutrition also it applies as early as possible when hemodynamic stability is also established. Why I'm talking about hemodynamic stability is, suppose a patient of septic shock, when they come to ICU, they are usually on high dose vasopressors like noradrenaline, vasopressins. And when these agents are on, usually there is occurs what you call is the blood supply is diverted from the intestines to other parts of the body. So when blood supply is diverted from the intestine to other major organs like liver, brain, or heart, then if you are feeding these patients, this patient cannot digest the fluid because there will be no peristalsis or decreased peristalsis. So once their blood pressure starts improving, you can always think about feeding these patients. So early enteral nutrition should be aimed to be achieved within 24 to 36 hours, that is within 2 days of the ICU admission. What are the routes? Common routes are the enteral ones and the parental one. Enteral one is the very commonly we say is the oral nasoenteric. It can be, or the PEG, that is percutaneous enteric gastrostomy or jejunostomy for postoperative patients. In parental, it is through the venous route. So either you have preferentially you have a central line, or in some cases a peripheral line also can work. So we talked about it, this nasogastric tube, it is from the nose. I'll just touch this. I think there was one session already devoted to feeding procedures, which is usually fixed at 60 to 70 centimeter at the nose. And usually we call it, some of the names are the Riles tube or Fricker's tube. What is Fricker's tube? It is actually a longer tube around 110 centimeters, and it has a stillet in it. So this makes the tube stiffer, and it is easier to manipulate and put it through. It makes it easier for insertions. And once the tube is inside, you can pull out the stillet as we do for endotracheal or the tracheostomy tubes. So this Freka tube is usually a bit easier to insert in the patients where it is otherwise difficult to insert, either due to difficult anatomy or patient is uncooperative. Nasogastric tube is the preferred route for giving enteral feeding. Orogastric tubes are not ideal, I would say, because only in patients who are deeply comatose, you can put a orogastric tube. Otherwise, once this patient starts waking up, and like this trauma patients or patients who are in ARDS, they tend to spit it out. Like they tend to, with their tongue, they displace the orogastric tube, and that increases the chances of aspiration. So orogastric tube only in few situations you can consider, but as soon as if the patient is waking up, there is increased movement of the mouth, it is better to convert it to a nasogastric tube. Percutaneous endoscopic gastrostomy is usually performed in patients who are having surgical patients, there are certain indications, or else in trauma patients who are deeply comatose for longer period of time. And this PEG is performed. And this nasogastric tube actually can stay in place for 3 to 6 months also. And small bowel also, these are mainly surgical indications. This we have discussed already. So these are usually the devices which are required for feeding, like a feeding tube. There is a 50 ml syringe is required. Gloves are required. You need a glass to measure the feed, stethoscope to confirm the placement of the nasogastric or orogastric tube, and a kidney tray for discarding any aspirates. So what are the feeding methods? Most commonly, these are two. This is a bolus method or a continuous method. Bolus method is usually followed in many places in India, as I see, and also in our center. So here there is an infusion of certain amount of feeding into the stomach over a period of say 5 to 10 minutes. Usually by gravity, the patient's head is elevated and the end of the feeding tube is elevated and it is poured into the tube. Advantage is it is more physiologic and pump is not required. Simply can be performed by hand. It is inexpensive and easy to administer, and also limits feeding time to, so that patient is free to ambulant if you are ambulating the patients out of bed or onto the wheelchair. But disadvantages is sometimes it increases the risk of aspiration, especially if the tube is not fixed at the proper place. If the tube is high up, it can come into the gastroesophageal junction or a little up, then it can, if the patient coughs, it can go into the lungs and cause aspiration. And if there is a hypotonic feed also, it may delay the gastric emptying. Few places that are continuous feeding. In abroad, actually many places, because they have, healthcare is still, it's borne by the state and it is not so expensive. Patient do not have to bear the cost. Many places they follow this continuous methods of feeding. And nowadays also in India, in some of the centers, this continuous feeding is followed. These are pre-prepared bags are coming, which you can hang, and the rate is set at which it will go continuously. The advantages are it may improve the tolerance in certain category of patients where gastric emptying is delayed. It may improve tolerance. It may reduce the risk of aspiration because it is going very slowly over a period of time and gives increased time for absorption. But it may reduce 24-hour infusion, and it is a bit cumbersome for patients, especially for patients who are getting out of bed for mobilization. A bit expensive also those bags are. Intermittent feeding is not followed in most of the places, and here with larger amount of feed, like around 200 to 300 ml of feed is given over a period of around half an hour to 1 hour every 4 to 6 hourly. So it needs it needs a bit of more time, and also there is increased risk of aspiration because you are giving a larger volume of feed over a period of time, but also can enhance the quality of life, allows greater mobility between the feedings. Because if you are giving a larger volume of feed over at a greater intervals, in between you get more free time to move out. And these are mostly for patients who have been discharged from ICUs onto healthcare settings or rehabilitation centers. Head end of the bed need to be elevated at least 30 to 45 degrees, and this is part of our fast hug bits as well. So head end has to be elevated. The feeding level should be higher than the stomach by at least 18 inches or more. The capping of the nasogastric tube has to be done, and it should be flushed with water after every feed and capped properly. Otherwise, initially in the first 1 hour, the feed might just come out. And whenever you're starting delivering this enteral feed, it has to start at the low rate and gradually reach the 24-hour volume slowly over next 24 to 48 hours. Now, one of the biggest dilemma or confusion is about gastric residual volume. That is the gastric aspirate. So how do we go about it? We need to aspirate before starting new feed to check the residual volume. Now, if it is more than 40 to 50% of, and if the patient is symptomatic, like there is bloating of the tummy, there is altered bowel movement, the medical team needs to be informed. And if it is less than 40%, then it has to be pushed back to the patient through the same tube. Prokinetic agents like metoclopramide or this lesuride, etc., can be given in case of if it continues and high residual volume continues to come. But also we have to make sure that patient has got bowel movements, or if the patient has got constipation for more than 2 to 3 days, you have to ensure either through laxative or through enema patient passes motion, then only the forward movement of food can happen. So this is what we discussed. This is a flowchart to say that what we just discussed regarding the aspiration, gastric aspirate. If it is more than 40 to 50% of the previous feed, if it is more than that, just hold feeding, push the aspirate back, and then check after 1 hour. If it is less than 50% of the previous feed, push the aspirate back and then resume feeding. Of course, also here also you have to consider about giving some prokinetic agents like perinom or lesurides. The adequate length of this nasogastric tube to be given is determined like that, like from the nose to the ear and to the epigastric area. Usually it is 60 to 70 centimeter at the nose minimum, and for fracas tube also, because it is longer, around 110 centimeter. Similarly, 60 to 70 centimeter at the nose is the best point to fix, because in case that during movement the tube gets dislodged, it will still be inside or below the level of the gastroesophageal sphincter. But if you are fixing it at say 50 centimeter, what will happen? Because the tip of the nasogastric feeding tube will come up above the gastroesophageal junction. So the feed which you are giving will accumulate in the throat, and with the slightest coughing or movement of the patient, patient might aspirate this fluid or this feed, and it can cause aspiration pneumonia. And many times, it just spills from the mouth also. That is why this length determination is very, very important and a simple step in preventing aspiration. You see what are the complications? I just got this few images to show you that this feeding tube might get caught in the chest and go into the one of the lungs. So it is very essential that we check the relative position before feeding. And usually these tubes are ready opaque so that you can see the end or placement of these tubes in case of there is doubt. If you have fed through a wrongly placed nasogastric tube, it can end in the lungs and cause pneumonia. So what are the different formulas available? The most common formulas are this normal feed is called isocaloric feed, where 1 ml contains 1 calories of feed. So around 1500 to 2000 ml of feed if you are giving, it gives around 1500 to 2000 kilocalories. And what about diabetic formulas? They are also isocaloric. 1 ml is equal to 1 calorie, sugar free generally, and lactose free and fiber rich. Hepatic feed contains also, it is usually calorie dense, because these patients usually need a bit of more sugars with low sodium, because patients with liver injury or chronic liver disease, they tend to retain sodium. So their feed has got low sodium and rich in the branched chain amino acids. Renal feed also calorie dense, because always remember, in patients with chronic kidney disease or acute on chronic kidney disease, they are on some kind of fluid restriction. So they are given usually calorie dense formula, so that in less volume they get more calories and proteins. With low electrolytes, which is usually low in potassium. Potassium is a concern in kidney patients. And also, I would say normal protein disease. Do not say this is to be corrected. This is usually normally or high protein for patients with even chronic kidney disease, because now it is believed that patients who have got chronic kidney disease or acute on chronic kidney disease, those who are on hemodialysis, actually they need more protein, because they are in a great catabolic state, and also during the process of dialysis, a lot of protein is lost from the body. So if they are able to absorb, they can take normal or high proteins, not low protein. So this is, it's a printing error, please ignore this. And peptide based formulas also are in use now for last more than 6 to 7 years, and they are greatly helpful in patients who have got issues with the gut absorptions for different reasons. They are usually semi-lentil or pre-digested formulas. What happens in patients, as I said, if their patient is recovering from septic shock, or those who have pancreatitis, or if they have any gut issues, they do not tend to absorb feed. For these patients, if we are giving a pre-digested formula, the absorption becomes easier and patient's calorie and protein needs are usually met. Kitchen blend feed is also available. Many places they still stick to this kitchen blend formulas, and these are also isocaloric feed. Many brands are available, or preparations are available in the market, which are disease specific enteral formulas for either diabetes, for kidney failure, for cancers, for pulmonary diseases and hepatic failures. So there are different permutation combinations in terms of energy content or protein content, and some of this immune nutrients as well. This we have discussed. Medications were given. It should be flushed with 10 ml of drinking water before and after administering the medications, and tablet and capsule should be thoroughly powdered before giving and mixing it with the water, but not with feed. In this context, I'll just mention that some of the tablets which are extended release tablets, they should not be usually given through the nasogastric tubes. If you need that kind of medicine, the other alternative regular medicine should be given. But extended release tablets, if they are crushed, the property is lost. So like one of the examples is Metexcel. These kind of medicines should not be given through nasogastric tube. Now, withholding nutrition in ICU is a frequent phenomenon, and it really interferes with the overall nutrition goals of these patients. So before withholding any feed, definitely we should check with the medical team. It has to be documented, and any replacement feed needs to be given, that has to be started. But if the feed has to been stopped for more than 2 hours, if the whatever feed is coming, if it has been kept for more than 2 hours, it should be discarded. And if you're giving the next feed, try to catch up for those previous feeds if possible in the next feed. And minimal amount of water should be given through the rice tube if feed has been on withhold. What are the do's and do nots? Regarding this feeding tube position, as I said, it at least 60 centimeters at the nose should be there. Always check for this aspirations, any loose motions or abdominal distension. So this comes under the G of the fast hug widths. So any abdominal distension or diarrhea or vomiting has to be very seriously noticed and discussed. If there are any gargle throat sounds in the throat, that also indicates that probably food is regurgitated and it is accumulated in the throat. So feed has to be withheld and it has to be assessed first. And some patient is coughing during the administration of the food. That means probably it is aspirating or it is regurgitating and going into the larynx or trachea. That's why the patient is coughing. So you have to either slow down or stop the feed that time, assess the patient, talk to the medical team, and then resume as necessary. Feed head end of the bed should always be elevated. And physiotherapy, it should be definitely deferred by at least half an hour to 1 hour after feeding, and no physiotherapy immediately after feed. This is a very, very important step, because many a times we have seen if the physiotherapist has no knowledge of the feed has been given, and if they start doing just physiotherapy, patient invariably will regurgitate, might aspirate, and even go into cardiac arrest. So which one is correct? Method of fixing, it's a way of fixing on the nose or on the upper lip. I would say patients, it is either is not bad. I mean, it can do either. But if a patient is usually semi-conscious, it is better to put it onto the nose and try to fix it from all angles rather than just leaving it with the 2 strips here. So nursing alerts, assess and inform if aspiration is more than 50% or recurrent if it has not passed stool for more than 2 days, if there is abdominal distension, vomiting, and there is pain or discomfort. Be watchful about the unnecessary fasting hours and interruption of feed before any procedure or event. So always cross-check with the medical team about the plan, because many a times, suppose a patient has been posted for surgery in the morning times, for whatever reason, the surgery might have got postponed and the patient keeps remaining fasting. So if the surgery is posted in the evening, patient can be given breakfast, or many a times we have seen if the cath lab procedure is scheduled for the evening, patient can be even given light lunch, because all they need is 4 to 6 hours of fasting. So the timing of the procedure has to be constantly, checked with the medical team, and any postponement of those things need to be documented. We have to follow all the infection control practices, use gloves after and before, and it is required to lower down the head immediate after feed. No, you keep the head up 30 to 40 degrees for at least 10 to 15 minutes, and then gradually lower the head, because that is the time required for the feed to go down into the stomach. So now what about the patients who cannot be given enteral feed? There are category of patients, there are issues where you cannot feed them through the enteral route. There you have to think about this parental route, either partial or total parental nutrition. Parental nutrition is nutrition being given through the intravenous route. It can be partial. That means when you're giving partial IV nutrition plus some enteral nutrition, or total parental nutrition where no enteral nutrition is being given. And it can be given either through a central line preferably, or at times through a peripheral line. You have to make sure that appropriate calories and proteins and lipids are being given, because these bags are pre-prepared usually, and many times we tend to forget the amount of protein or calorie which is in the bag. So you have to assess also regularly that how much calorie and proteins are there in that bag, and if it needs to be supplemented further. Of course, you have to keep in mind about the volume restrictions, because patients who have got either chronic kidney diseases or acute and chronic kidney diseases, or even cardiac dysfunction or heart dysfunctions, they are on some kind of fluid restrictions like 1 to 1.5 liters. So whenever you are giving, say 1 liter of fluid, you also have to keep in mind that these patients in ICU are also receiving some antibiotics. So that also adds to fluid. They might be having some liquid medications. They're also drinking some water if they're conscious enough. So all these some fluids are also coming from the medication. So from the nutrition, how much nutrition you can give through fluid or through the feed, that also one has to be careful, and nursing team has to chart that at the end of the day. So what are the indications for total parental nutrition? So somebody who, whatever reasons, is not able to feed through the enteral route for more than 3 to 5 days. And many times patients who come to a hospital or ICU after surgery, say for CA colon, cancer colon, these patients, if you take carefully their history, they may not have eaten properly for at least 2 to 3 weeks before. So they are actually been some kind of fasting for many days before they have undergone these surgeries. So there has to be this has to be taken care immediately. And if there is no immediate plan of feeding them within the next 48 hours, they should be started on some kind of parental nutrition. Those who have complicated gastrointestinal fistula, short bowel syndromes, or inflammatory diseases, or acute radiation enteritis. This is for patients who receive radiation therapy for their malignancies. Those who have acute chemotherapy toxicity, some of these chemotherapy agents are so much nauseating that the patients feel so much nauseating that they are not able to take orally. So these are the patients, if they are fasting for more than 3 to 5 days, there also you have to consider giving parental nutrition. Patients who have got decompensated hepatic failure, again, they tend to reject feed. They do not, if you have treated for those patients, these patients usually do not absorb feed because the abdomen is distended due to ascites. They have so many hormonal changes in the body. So they also need to be given partial parental nutrition. Among the routes, it is usually preferred is the central route. And among the central routes, it is subclavian line is the best one, followed by the internal jugular line, and femoral root veins are usually not the best ones for TPN because it is close to anogenital area and chances of infection is very high. One can consider this peripheral venous lines. However, either the central line or for peripheral venous line, one lumen has to be completely dedicated for total parental nutrition. So whatever route or lumen through which you are giving this parental nutrition should not be used for giving other medications. Otherwise, the chances of infection increases. And solutions who have got high osmolarity, say more than 750 milliosmol per kg, should be infused through large central veins. Because obvious reasons, if you are giving a hyperosmolar solution through a peripheral line, chances of thrombophlebitis will be more. We have already discussed this about the line. Preferred line is the subclavian vein, which is a stable site. In patients, acceptability is also more, and infection rates are low. The catheter has to be, one lumen has to be dedicated for that. Also nowadays there has been increase in the usage of this PICC lines, peripherally inserted central lines. This is usually put in the basilic vein in the cubital fossa and can be used in both IP setting and also for long-term outpatient therapies. In our center, we are doing it commonly, for chemotherapy patients who come to take chemotherapy on the OPD basis. And also these lines can be utilized for feeding at the community level as well. It can stay for up to 3 to 6 months also if properly taken care. Peripheral partial nutrition we have already discussed. Usually low osmolar solutions are given through this. The equivalent of around 12.5% of dextrose is there. This is mainly used for supplementation for short-term feeding. If somebody needs total parental nutrition for longer time, it is best to have a central line in place. So this triple lumen bags, I think most of my colleagues and friends who are listening here are familiar with this. So this triple lumen bags, actually there are 3 chambers. One contains dextrose, the other one contains protein, the other one contains lipids. So when you are going to feed the patient, at that time only all these 3 chambers are mixed and the solution is administered. Now it is designed in such a way that up to 70% of the calorie come from non-protein sources. So protein should not be counted for calorie requirement. Protein should be counted only for anabolic reasons, that is for muscle building. And the dextrose solutions which are used are usually hyperosmolar and should be, that is the reason that it is preferably given through large central veins. Amino acid solutions, again, it is taken care of. If you see a bag, if you have seen such a bag, you can see the composition of that particular nutrition bag, and see it contains usually 50% of essential amino acid and 50% of non-essential or semi-essential amino acids. So amino acids or proteins are not to be counted for calorie measure supplement. Similarly, lipid emulsions are also very much important for cellular integrity and nerves. They are usually long chain triglycerides or medium chain triglycerides are there, usually derived from vegetable oils and are rich in following fatty acids. They are available in 10% or 20% strengths, and 10% emulsions usually provide approximately 1 calories per ml. So 500, if you've seen the 500 ml bottles are available, so 500 ml will provide 500 of kilocalories, and 20% emulsion will provide 2 cals per ml. Many times, many physicians, critical care physicians or surgeons, they prefer to use partial parental nutrition by giving only lipid formulations or amino acids. But if you're giving amino acids, this is not to be counted for calories. Remember, only the dextrose and the lipid ones should be taken into consideration for the total calories. And unlike the hypertonic dextrose solutions, usually lipid emulsions are isotonic to the plasma. It can be infused through peripheral veins as well. And for patient, these triglycerides which are there in the lipid bags, once they are transiently introduced into the bloodstream, are not cleared for around 8 to 10 hours. And these lipid infusions can sometimes produce a transient lipemic or whitish plasma. So if you are drawing blood sample at that time, the blood sample might appear a little bit whitish due to this triglycerides. Now, how much calories and proteins? I'll just stop here. I'll just, I've deliberately not put the answers here, or question here actually. How much protein on calories do we need for a patient when we feed in ICU? Dr. Tyagi, can I ask that question here? No? And people, colleagues who want to answer can type in their answers. How much calories and proteins? Okay. Are you getting any response? So I'll just continue. Maybe at the end, when there are questions, I'll take it. And also when you're giving them parental nutrition, we have to supplement the vitamins. Usually it is given as 1 ampule of multivitamins, or folic acid or vitamin K is supplemented. Even trace elements or micronutrients are also supplemented at least once or twice a week. The trace elements are usually copper, manganese, and zinc, and chromium. Complications are usually divided into the complications due to the central line itself, which can be pneumothorax or hemothorax or brachial plexus injury if you're putting it in the neck, or catheter infections. For peripheral venous access, usually it is thrombophlebitis, if it is due to hyperosmolar solutions and if it is used for a longer period of time. Other one is the hyperglycemia, which is the most important one due to high blood sugars, because as we saw, the glucose solutions are usually high concentrated. It can cause sepsis again, because these lines become very fertile ground for the bacteria to grow. That could be liver dysfunctions, metabolic bone diseases like osteoporosis. So the challenges are many that when we think about delivery of nutrition in these patients, because the concept of nutrition, it is a mindset where we see dealing with a critically ill patient who has got multi-organ failure. Usually nutrition does not take priority over other organ issues like antibiotics, hemodynamics, or renal failure. So one has to think of nutrition first, and about the adequacy of calories and proteins also we have to keep in mind. It is usually around 25 to 30 kilocalories per kg per ideal body weight, and also protein wise it is usually 1.5 to 2 gram per kg body weight. As I said, the protein is not to be counted in the calculation of calories. Now deciding the route, that has to be done according to the patient profile. If there are a risk of nasal tube in patients with coagulopathy, we have to obviate that. But again, if you're not able to put a feeding tube, it delays administration of the nutrition. Method that we have already discussed all these things. And diarrhea in ICU are one of the other issues actually, which is very often ignored. Most of the times diarrhea in ICU is usually associated with antibiotic, and if due to prolonged administration of antibiotics. So once the patient starts improving clinically from sepsis, we have to start considering de-escalation of antibiotics. Otherwise, it invariably gives rise to diarrheas, and then and we later on actually end up doing more of investigations or withholding feeds, which unnecessarily interfere with the patient's nutrition status and might cause also distension of the abdomen, pain sometimes. Assessment of ongoing nutrition has to be periodically done on a daily basis, because many a times you see for a variety of reasons the nutrition, the feed would have been held and it is not in the knowledge of the medical team. So on a daily basis, one must calculate how much protein and calorie the patient has received in the last 24 hours and if it needs any modification. Aspirate problem we have already discussed. The rate, deciding the route regarding the enteral versus parental route that we have already discussed. I'll just mention about the post-pyloric or the pre-pyloric feeding. This is usually considered in the context of patients who are having pancreatitis. And there was a belief that patients who are giving nasojejunal tube, the tube is placed beyond the duodenum. These patients have better feed tolerance for those enteral feedings. But it is now minimally literature or research has come which tells us that there is no difference in the tolerance of feed for both post-pyloric or pre-pyloric feeding. Pyloric means it's one of the distal end of the stomach. So the nasogastric tube, if it is above that pylorus or beyond the pylorus, the enteral tube feeding can be given in the appropriate patients. That we have already discussed. And when this many times you see, if they do not have a feeding protocol in your ICU, the prescription must be missing. So when you see the patients once in a daily round, there must be a prescription of mentioning how much calorie, how much protein you want for that patient. As you saw about the first hug bits, one must write about the desirable or the target calories and the target proteins for that patients. And in the next day, after 24 hours, it should be always reviewed how much of that actually the patient has received or not, and if needs to be modified. That's the way to go about prescription of nutrition and also monitoring nutrition, because it leads to otherwise confusion. Interruption of feeds are frequent, and we have to be very careful about how long the patient needs to fast, as I discussed for one of the proposed procedures, and also for investigations like ultrasound, CT scans, or endoscopy. Also, it has to be properly planned, and communication has to happen between the person who will proceed or the team who will perform this procedure and the bedside nursings. For intubated patients, please keep in mind that only for abdominal surgeries or airway surgeries, patients should be fasting for at least 6 hours for intubated patients, because you are going to interfere with the airway or the GI tract. For all other surgeries like limb, if there is a fractured limb or there is a flap to be done for a bed sore or craniotomy, patient needs maximum 2 hours of fasting. Why? Because this patient is intubated, the airway is already protected, and we have an esogastric tube, gastric tube separately. So if you have to give anesthesia to this patient, we just can aspirate the tube and aspirate the nasogastric tube, and patient's tummy will be empty. So and it's not a high risk procedure for aspiration. But if you are going to do surgery for the intestine or the abdominal surgeries or airway surgeries, where slightest chance of risk also can cause the patient, life-threatening issues, there you need to fast them for at least 6 hours. And for non-intubated patient, fasting is required as for other patients, or at least that means usually 6 to 8 hours. So diarrhea in ICU, we have already discussed. Most commonly, the causes are unnecessary prolonged use of antibiotics that has to be stopped first. And also, excess or prolonged use of proton pump inhibitors like pantoprazole also is one of the culprits. So this has to be kept in mind that patients who are usually feeding well, and after a certain beyond 72 hours to 96 hours, if they're hemodynamically stable, they're not on any anticoagulants or high dose heparin, they do not need this pantoprazole or this proton pump inhibitors. And if your feed is usually concentrated, like very high calories or proteins are there, temporarily you have to reduce the content of calories and protein in a patient who's having diarrhea. Metabolic complications are most commonly the hyperglycemia one, and sugar control is very, very important for patients in ICU because it is directly related with all outcomes for a patient who has been in intensive care units. So what is your target? Target is between 110 to 180 milligram percent. And if the blood sugar is persistently higher than 250 milligram percent, inform your medical team and initiate insulin infusions. Micronutrient deficiencies can arise, and that has to be seen by the dietitians and again the medical team. Something called refeeding syndrome, I'll not go into the details, can happen in a patient who has been fasting for a long period of time, say more than 5 days, 7 days, or even 2 weeks. And suddenly they have come to ICU and you have started feeding them. So it is called refeeding, feeding after a gap of time. And these patients, you see a precipitous or sudden fall in the level of potassium or magnesium or calcium. They become hypokalemia, and you have to give them large amount of usually potassium, magnesium, or calcium, and sometimes sodium also, because body which was not feeding for long period of time, once you start feeding them, the cellular activity increases. So these levels of electrolytes suddenly decrease. That could be deranged liver functions also mostly from this TPN. Hypertriglyceridemia can happen in patients already who are hypertensive or having coronary artery diseases. We have to be careful. And sepsis due to parental nutrition is always a risk factor. So in case of any new sepsis, always look for TPN associated sepsis, either the lines or the content. Constipation is very common in patients who have got multi-organ dysfunction in ICU, because they'll be on sedation, they'll be on vasopressors, and they might be having varying degrees of neuropathies like diabetic neuropathies, or if they have more comorbidities. So constipation has to be always, addressed promptly. And fiber should be avoided in patients who are on vasopressors, because fibers, remember, they need long time to be digested and then tend to form fiber wedgers in the intestines. And these are difficult to clear because peristalsis is not very strong for a patient who is recovering from, say, sepsis or septic shock, who has been on vasopressors like noradrenaline. So fiber should be avoided in short for these patients. And prolonged constipation, remember, is an important cause of gut-derived sepsis, because patients who are having, absent peristalsis or gastric stasis for long period of time, there occurs bacterial translocation from the gut into the bloodstream, causing sepsis. And this becomes very challenging to diagnose this kind of sepsis, because you not grow anything from, say, urine or other invasive catheters like tracheal secretions, and only blood culture, if you have drawn it properly, sometimes it can give you the organisms. Abdominal distension, you have already discussed this. There could be some intestinal bands or kinks, neurological or autonomic dysfunctions, like patients who have got head injuries, or they have myasthenia gravis or GBS syndromes. They can, or spinal cord traumas, they usually manifest autonomic dysfunctions, where the patient can have abdominal distensions. Or sometimes, very rarely, you see volvulus, where there is a rotation of the large gut on itself, You just need to rest the gut and then improve. Clostridium difficile colitis is a possibility in cases of patients who develop antibiotic-associated diarrheas and has to be treated appropriately. So coming to the questions. So I'll just quickly go through these questions, and these are the last ones. 45-year-old male with acute necrotizing pancreatitis. Now he has acute kidney injury and has dialysis done for him. He has a high nasogastric aspirate around 900 ml, then next day 750 ml, high grade fever. Creatinine is normal now. So what will be your nutrition plan? There is day 6 already, and there is high nasogastric aspirate. So what will be your nutrition plan? A, B, and C. Please put in your answers.
Please put your answer in the chat box.
Somebody written B.
Yeah.
Please feel free to write the answers because we don't know you. So we cannot talk to you directly. Nobody will know who are you. Put your answers.
B.
It is a test to see that if you're still awake or you're interested in the talk at all. It's difficult in the evening time to listen to a lecture, but I think it's very, very useful and very important for nurses and for if you're from exam point of view also. Most of you are writing actually, I think there is no mixture.
Most of answering B, C. One is answering C and one is A.
Okay, so more are in favor of parental nutrition partial. So it is good that you are considering to feed these patients because it is already day 6, that is more than day 5. So the patient definitely need nutrition. Parental nutrition is a choice, and by meaning partial, I think it is the most appropriate choice answer. That is parental nutrition partial, because these patients, if you are still interested, you can try giving some enteral feed, low dose, but 750 ml is a bit high. Unless then once the nasogastric aspirate becomes less than 200 or 300 ml, you can start low dose of enteral feed. But till then, at least you can start 1 liter or 1.2 liter bags of parental nutrition, because this patient has got acute kidney injury. So there is some degree of volume restriction is applied. So partial parental nutrition, at least to start with, is a good choice in this case. So thank you very much for responding. So please be prepared for the next question, which is also a real patient in ICU. So this is a 34-year-old man who had a old snake bite. He had snake bite and treated in the periphery, and now came to us with acute kidney injury on hemodialysis. He had developed aspiration pneumonia sometime when he was in altered sensorium. He's on NIV and on dialysis. He was slightly disoriented, so he pulled out the nasogastric tube. Now is not cooperative with the nasogastric tube. We are giving him renal semisolids. So how much he is on hemodialysis? How much protein would you like to give him? His body weight is 60 kilograms. Please put in your answers.
One is answer A, 120 gram. A. Most of the answer is A.
A is 60 grams, no? A is 60 grams.
120. No, sorry, 60 gram. 60. Most of the answer is A.
Okay. I think all responses come so far is A. So I think I try to mention that sometime that so patient who has got acute kidney injury on hemodialysis, actually they are the ones who have got more catabolism. That means they have more wasting from their body. And remember, during the process of hemodialysis, when the blood is going to the filter, it is getting cleaned and returned, there is a lot of loss of protein also happens from the body. So these patients who are on hemodialysis actually require more protein. So something to the range of 1.5 to 2 grams per kg. So if you take it 1.5 grams for 60 kg, it will be 90 grams. Or if you are a bit bold, you can take it 2 grams per kg, it will be 120 gram. So usually if you're not very comfortable, one is not comfortable to give this much of protein at the beginning, most appropriate in this patient will be at least 90 grams, but certainly not low proteins, because these patients are highly catabolic, number one. Number two, they lose protein during dialysis also. So this whole concept that kidney patient should be given low protein diet is no more applicable. Please remember this, and this is a universal acceptance now, and it is believed, and there is a consensus that they should be given higher protein, at least 1.5 to 2 gram per kg. And this is also important from your exam point of view. Next question. Now, this is also a real case, a young fellow who had idiopathic thrombocytopenic purpura. Thrombocytopenic means they had low platelet count. There are purpuric patches on the body with transfusion of platelets and red blood cell. That now the patient had got GI bleed for 3 days when the platelet count was low. So he was not eating properly through mouth, and also developed rashes on the lip and oral cavity and throat. And there was so much rashes actually on this patient that it was very painful. We are giving this oral jellies, mucin jellies, and other supplementary agents. So, but he was conscious enough. We could not put a Rice tube for this nasogastric tube for this patient. He did not want one. So, what will be the, and he was otherwise hemodynamically stable, fully conscious on oxygen, just 1 or 2 liters. So, what is the best way to feed him? A, B, and C. The very real life practical scenarios. You see these patients in ICU, and they are just challenges for us. Please type in your answers.
C, B, C, B or C. Most of the answer is B or C.
Yes. So yeah, it is good that nobody wants a nasogastric tube with sedation for a patient who is conscious. It is like torturing the patient. So we do not want option A. B and C are the options for us. Now between B and C, I would say it is obviously you can think of giving a parental nutrition, or you can think of liquid formula feeds. Say, remember this, what are these feeds that we give? These are these formula feeds and come in this boxes, and these are usually prepared with around 150 to 200 of either lukewarm water or milk. So these milk, these are like the energy drinks that are available in the market, like Horlicks or Bonvita. So one of the options is also giving them liquid formula feed. As the feed comes in a glass, you can just prepare this feed in the bedside and give them every second or fourth hourly, because these patients, they can just drink well because he has got rashes on the oral cavity and throat. But so he can calories and proteins both. Parental nutrition also a choice, but remember this patient also has got thrombocytopenia. So when platelet counts are low, putting central line is also risky. There is a risk of bleeding. If it is more than say 50,000, one can do a central line. But if it is a bit of invasive line, so one can first try with this liquid formula feeds. I mean all this protein feeds or this formula feeds which are available in the market. And if the patient is drinking and accepting well, that is serve the purpose. But even if that is also patient is not able to swallow due to the throat ulcers, then of course you have to go for parental nutrition. And which line will you put for parental nutrition? You have to give TPN for this patient. Subclavian, internal jugular, or femoral line. You can type in subclavian, internal jugular, or femoral. Subclavian. Yes, because that is the best one. But of course, you have to see the sorry, the platelet count is more than 50,000 or not. Now, one patient is on, I think we're getting short.
Short of time.
5 more minutes. Huh?
Yeah.
This patient has got a polytrauma patient on ventilator scheduled for femur fracture surgery at 12 noon. He's on enteral feet, right? But now the surgeons want also an ultrasound abdomen to rule out any liver injury. So for ultrasound abdomen, how long will you fasting? 2 hours, 4 hours, 6 hours, or 10 hours for ultrasound abdomen? Two hours.
Some are 4 hours.
No, everybody is 2 hours, no?
Yeah.
A is 2 hours.
Yeah.
2 hours.
2 hours.
Yeah. For ultrasound abdomen, remember, usually when you are doing it, we aim to look for the liver and the gallbladder and other intestines also. So at least 4 to 6 hours of fasting is required. So you want the food to be completely gone from the level of upper GI tract. So at least 6 hours of fasting will be required for an ultrasound abdomen. How suppose if this patient is for surgery now for the femur, how long will you fast him for GA, for general anesthesia for femur surgery? Because he is on ventilator. He's on ventilator and he has to have a femur surgery, right? and he has an nasogastric tube. So how long will you fast him for his femur surgery?
Some are filling 6 hours, 8 hours, 2 hours, all answer.
All answers. So, okay, I'll just say this because this is something I wanted to point out also. Because this patient is on ventilator, he has a nasogastric tube already, and it is for the femur surgery. Femur is one of the limbs, right? So even if you have given him feed, you just aspirate the nasogastric tube. So something like 2 hours is also adequate because airway is already protected, right? Airway and the GI tract is separate here. So you can just aspirate the nasogastric tube and the tummy will be empty. So if you are giving GI also, you do not have any risk of vomiting or aspirations. So for non-GI or airway surgeries, a patient who is on ventilator with nasogastric tube, 2 hours is adequate. For sugar control, a patient on colon cancer is on TPN, blood sugar 4 hours apart is more than 300 mg/%. Best way to control sugar is, because sugar control is very important, and please type in your answers. Yes, insulin infusion. I think most of us are clear in that you need insulin infusion, and target sugar is 110 to 180. Immunonutrition has shown no superiority. It has no role except for no role in regular ICU patients except for patients who have got polytrauma and few probably the burn patients. So take home message that nurses should take the lead role in nutrition of ICU patients. Think of nutrition in any patients who is admitted to ICU as soon as possible. And enteral route is better, but think of the other routes as appropriate, as we did on all few of the questions. Assess the adequacy of calorie, protein, and fat on a daily basis. Frequent interruptions of feed should be minimized. Nail by mouth orders should be reviewed frequently. You have to see the timing of the procedures or the investigations, and it should be initiated by staffs and junior members of the medical team and the bedside nurses. Because remember, you are the one who are actually guarding the patients by the bedside, and you should communicate. Diarrheas in ICU should be wisely investigated. It could be due to the feed, antibiotics, and if unattended actually also leads to bed sore syndrome dependent areas. So very important for nurses to point this. Commonest cause of diarrhea, as I said, is due to antibiotics. Also, you should take part in the antibiotic stewardship in a way by asking to review the antibiotics to stop if it is possible. Immunonutrition has no demonstrated benefit rather than can cause harm. Immunonutrition, one of the example is the glutamine. That's also you can discuss with the medical team. And sugar control is very, very important. Target is 100 to 180 mg/%. Thank you very much for your patient listening. I think it's just exactly 1 hour.
Yeah, exactly. Thank you very much, Dr. Sharmili, for elaborative and very basic talk on the ICU, very neglected topic in most of the ICU, I think. But this is very, very important topic for all nursing and for all duty doctors to follow the chart of nutrition. When we take the over, please always remember patient is fasting. Why is not taking nutrition? This is a therapeutic. Treat as a therapeutic, not a adjuvant therapy nutrition. So very, very good topic for the ICU and to reduce the mortality, morbidity, and hospital stay. Save life and save money if you follow properly nutrition topic. Thank you.
Yeah, very truly you said, sir, about save money and save life.
Life.
Thank you. Any questions? Somebody can unmute and ask or chat, type in, or else we'll stop here. किसी को कुछ पूछना है तो सीधा अनम्यूट करके पूछो.
One question is, I think no question.
Okay, sir.
Thank you very much.
Thank you, sir, and thank you,
Bye.
team.
Yeah. Bye. Take care.
Yes. Thank you.